I get the easy bit because everyone's already done the hard work and been introduced to all the trials. But I was originally a bit of a skeptic, and actually it is a treatment that works, but it's a treatment that works if we select the right patients. And so therefore it's about dissecting down those trials, and a lot of it's already been alluded to by Ahmed, as to the people that really might benefit, and to avoid sending us things that we don't want to be seeing. I have some declarations. I've had previous funding and research funding and sponsorship from various companies, including companies that do make stenting devices. But actually what we're looking for is this: how to select the salvageable from the ones that we have got no chance of salvaging at all. So which patients do we really want to benefit from this treatment if we're going to put it in place? I have to point out that we do not have a regional service in West Yorkshire. But if we are going to develop one, we're going to need different approaches probably for the anterior and posterior circulations. We've now got evidence for the anterior circulation. If we're going to work up our patients, we must always remember current NICE guidance when we're consenting patients, to tell them whether it is or is not approved and what the current conditions are. The individual patient in front of you is the person you're going to want to make a very realistic outcome response and provide information to the patients and relatives before you undertake any intervention. And if in a region that means you're doing drip and ship and moving people into the region and into a centre that's miles away, you have to be able to pre-warn them before you've sent them that you may arrive there and they may actually say, no, you're not suitable, and send you straight back. And you should always be clear if you're working outside of the evidence. So actually, we need to know what's in those trials, and we need to know what the patients who are going to benefit are. And if we're going to send a 90-year-old with an NIHSS score of 27, we need to be very honest and say this is well outside of the evidence. So, anterior circulation disease, we want to select a group of patients that are going to do better with intra-arterial, and if we're going to do that, that's treatments that are shown in the trials to date. And if we look at the mean age of the trials, they come out at 60 to 70-year-olds. So actually, if you're going to start sending 80-year-olds, there is no evidence at all, really. Very, very, very small numbers of patients were treated with intra-arterial thrombectomy who are over the age of 70. Very small numbers. So there really isn't any evidence. The median NIHSS scores in the majority of those trials were 14 to 17. So that's the median scores. That's where the majority of the patients were. There was really no evidence in the massive strokes, the NIHSS is of 28, if we take the current trial data. The other point is that we should not be denying patients access to a treatment we know works while we're trying to work up patients to deliver intra-arterial treatments. So actually, we should be focusing an awful lot on making sure this happens. And the reason that that's very important is there are significant numbers of patients who have small and medium vessel disease that wouldn't be eligible. And if we delay delivering the IV treatment, it's not going to help those patients. And actually, if you think about all those trials that were positive, we'll go through them again. We had a group of trials in 2013 that were all negative. Those were comparing intra-arterial interventions without giving IV TPA versus patients who'd had IV TPA. And they came out as equivalent, as negative. The later set of trials that we've had that have come out positive, all the patients had IV TPA plus or minus intra-arterial treatment. Now that probably should be telling us something, that maybe the intra-arterial treatments are much more effective as long as you're delivering intravenous. And if our services are up to speed to deliver the intravenous nice and early, rapidly, we can then start thinking about adding the extra treatments on top. But if we don't give the IV TPA, we're probably not going to get the same outcomes we got from the clinical trials, because it's a completely different group of patients. And also, we want patients that have got similar characteristics if we're going to intervene. And of course, there is significant selection bias in trial results. In fact, if you look at one of those clinical trials that was presented, there were 7,000 patients screened to get 70 patients that were put into the trial. So there's a lot of selection bias, and therefore if we're going to offer these treatments, we should be offering treatments to the patients that are in the trials. The lacuna subset of strokes. Now, Dr. San already showed a slide that said that 25% of our patients have got these sort of strokes, lacuna strokes. They're not going to benefit from intra-arterial intervention, but there is definite evidence that small lacuna strokes, particularly in the sort of the basal ganglia region, can benefit from intravenous therapy. So we've got to make sure we deliver that intravenous therapy nice and early. And this is what I was on about those trials. So if we go back to the IMS3 study, where there was no benefit, this is a study that there was benefit. Two things were different, of course. These patients had endovascular therapy or just intravenous TPA. These patients in the Mr. Clean trial had both together. But the other thing they had different about them is the time from stroke onset to initiation of TPA. Patients were treated much quicker in the recent trials, almost an hour quicker. So all the patients were being put through the beginning of the pathway much quicker, they were moving through much quicker, the whole process was much slicker, telling us that both sets of treatments, which we already know with IV TPA, but also with intra-arterial interventions, the faster you do them, the better the outcomes. You need to be moving through quickly. And if you look at the ESCAPE trial, their data also confirms that time matters, because they excluded patients who they couldn't get through the system and have a groin puncture and be in the arteries within 60 minutes. You couldn't be randomised in that trial. So that selected patients who could be treated really fast. If you're going to treat these patients, you're doing the whole process fast. You're getting the IV TPA on board fast, and you're getting the intra-arterial intervention fast. And we get exactly the same if we start looking at all the trials put together into a very simple plot. Mean time to puncture and recanalization of the vessel, the longer it takes to get that vessel open, the lower the percentage of patients who have a good outcome. You get it open quickly, you get them through the process quickly, you get the IV TPA on board, you get the intra-arterial intervention on board quicker, you get a very good outcome. So, and we're talking here 120 minutes, so that's 2 hours. So we're still looking at the same time windows we were looking at. We can make vessels look wonderful, and our neuroradiology colleagues can make the vessels look clean and pristine, but the point is the brain's already dead. You've missed that time window. This was a meta-analysis that came out, but it didn't have any of the recent trials. It just had those from 2013, which were all the negative trials, and that's when it was just starting to show some benefit from intervention, and that's we've got the more recent trials. So I don't want to say that this is something we shouldn't be delivering. I think it's something we should be. I was a consultant in Sheffield, and those two stacks were beautifully blown up, and lots of people stood around and watched everything fall apart around them. I think we do need to look forward and start trying to deliver these therapies, but we've got to deliver it to the right people. So we're delivering it to people in the correct amount of time, and delivering it to the patients with the right vessels that are occluded. We've already alluded to the fact that most of these trials, the big trials from beforehand, had involvements of the ICA or the M1 segments. Most of the patients, if you look at them, that are recruited who just had an M2 branch, very small numbers. The evidence for the M2 branches aren't really there. There were relatively low numbers of patients that were recruited that had A1 segment disease. So the majority of the trials are either ICA occlusions or M1 segment occlusions. That's where there's clear evidence. And we know that there's benefit. And so those are the patients we want to select. And we know that...
you say M1, not M2 then?
There, if you go back to the data, M2, 7% of the patients in the trials. If you go M2, single M2, 3% of patients in the trials. So actually the evidence is all there for the M1s and the ICAs. And actually the M1s are probably the easier ones to spot than the distal M2s. Of course it really depends what M2 you've taken out. If it's not recanalizing with IV TPA, and the patient's still got a deficit, and it's a very important deficit for them, you might consider it. If we're to work on the evidence and work at services being developed, that's pushing for stuff that's got the evidence. So it would be to say we're developing services that would be treating these people that we know do badly, but they do much better with treatments, and it's the M1 type disease, which actually relatively is probably the easier disease to spot on your CTAs and your CTs and your MRAs if you're having to look at them yourself. Those are the ones that are easy to spot. But there really isn't much evidence for the M2s because there's not the numbers of patients in the trials. If you're going to consent patients, there's a couple of things to point out. The intervention, actually, in most of the trials, didn't really make that much difference to the death rates. It just made a major difference to how disabled people were. So you got much better modified ranking outcomes. If you ended up in these trials having the procedure, that you had an equal chance of dying, yes or no, but you improved outcome. So that's important when you're consenting patients. We've improved outcome. Better, less disability. Similar evidence in the other trials. The death rates were relatively similar. But the outcomes generally started shifting. And the same with the MR rescue study, which was looked at penumbra. There was a general movement to have improvement in outcomes, but death rates were reasonably similar. So I think when we're working up patients, and we're looking at putting together protocols if we ever develop fully, properly funded regional services, we're looking to work up patients that are presenting with severe anterior circulation strokes with an M1 occlusion mainly. We might accept a few of the M2s, but the majority of the evidence is M1. We should be able to clearly have demonstrated that with a CTA or MRI. And the reason we want to work those patients up is we know that they do badly if you just give them IV TPA alone. But we do know that you need to give the IV TPA because all those trials that didn't work never had the IV TPA beforehand. All the trials that have worked had the IV TPA and the intervention. Maybe we should look at the patients that are coming in and thinking, clinically, this looks like it's going to be one of those big M1 occlusions. And actually, we should just get the CTA done at the initial scanning. It's going to save time. We don't want to necessarily CTA every patient that comes through. One, will overload our radiology department. Two, we're going to expose patients to a higher dose of radiation. And three, we're going to expose them to contrast. But if clinically you think this is an NIHSS MCA territory looking stroke, we might want the CTA. The time from onset to treatment, if we really look at those trials, when we really dissect it back down, the intervention has to be realistically achieved within the same time windows we have for TPA, for IV. Realistically, groin puncture and everything else, to get the best outcomes. And so can we achieve delivering the IV thrombolysis and getting them through the system and deciding it's failed and getting a groin puncture and getting in to deliver that intervention within 4.5 hours. If we go beyond that, the outcomes don't look quite so good. So really, that's what we're still looking at. And if you really look at the IV TPA, the Mr. Clean IV TPA delivery, so the first part of the treatment, the majority of those patients were treated in 90 minutes with IV TPA. Most of the UK doesn't treat almost 90% of its patients within 90 minutes. Most of our patients turn up about 2 and a bit hours. So we're already at the front end, we're outside of the window of what clinical trials are doing.
90 minutes from onset of stroke?
90 minutes from onset of stroke. That's how fast they would. And Mr. Clean was done in Holland, and then part about the Mr. Clean trial is that in order to have any kind of intervention, patients had to join the trial. There was no option. They couldn't do anything else. It was the government mandated funding. That's the way they did it. But Holland's quite a small country, and lots of people are very close to major stroke units, so they could deliver the IV TPA really, really fast, and they could get that 90 minutes. And then that gave them plenty of time to also make that decision and deliver randomise and deliver the IA therapy and get it all done within 260 minutes, within 4 hours. Most of their patients were treated within that trial, if they had to. And we'll talk about
drip and ship.
They do drip and ship. Aspect score. Anyone with an aspect score of less than 7 did badly in the trials. So we'll briefly talk about aspect score, but most people should be able to look at aspect score. So the Alberta Stroke Programme Early CT score aspects. Very simple to use. Everyone starts with a score of 10. We've all got a score of 10 if you scan our heads now. Hopefully. Although you might need some caffeine coming up. 10 predetermined areas on your CT scan on a couple of slices. And for each of these areas that you think there is early ischemic change in, you subtract 1 from 10. So if you've got ischemic change in this area, and this area here, your score is going to be 7. If you've got ischemic change in the head of the chordae, in the insular ribbon, in the lentiform, in the internal capsule, you're going to pick up those 4. So you've got a score of 6. Based on plain CT. So if you pick up this chunk here, which we see a lot of change on, you're going to have a score of about 4 or 5. You've got too much early change probably to do well. So the trials, aspect score less than 7, you did badly. You should not really select those patients. So I think really what we're looking to do is to do urgent clinical assessment to speed up our front door before we start worrying about how many we're going to be trying to ship through the system. We get the right age group, we get them with a good pre-morbid modified ranking score. We know that that NIHSS score is in that good range, and we've got an aspect score all worked up when we start working it. We're going to need bloods and cannula. We need a CT head, and I think actually we probably should be thinking about that CTA being done nice and early, so that we've got all the information. Everyone should be consented and started treatment with the IV-TPA, because that seems to be part of this package of benefit. And if we see a proximal occlusion, we should start thinking, actually, is this something that's not going to open? Should we be looking at the next process? Should we look at the feasibility of can we deliver the next stage within a time window? And we may need to be going there. When we have the services in place, that's when we'll be shipping people to do the interventional radiology suitability based on imaging. But it's that beginning part of the pathway that is equally important in delivering these services to get these brilliant outcomes that we can get. So I'm less of a cynic than I was previously. I believe this stuff works, but I believe it's a complete package. So this is how we've got to deliver it, this is what we've got to do, and this is why we've got to select the patients right. And that's why in the next section, you'll be looking through and working through some cases and doing exactly that, and looking at the aspect scores, and looking at the NIHSSs, and looking at whether you've got an M1, M2 occlusion, and working out whether that's a patient that's going to do well or not before you start treating them. Thank you.
The challenge for me as a stroke physician is answering that question of whether the patient is responding or not responding to treatment.
Yeah, it's difficult.
Should we be, because basically, I'm loud enough, you see. Basically, it's time is of the essence.
Yeah,
You're
absolutely.
already saying to us they're arriving late. You know how difficult it is to be having that cross. I could just get on the phone to Salford and I'll be 20 minutes just through the answering machine trying to get hold of the neurologist or the neurointerventionist. And then the CTA and all the issues.
Yeah.
But what is clear is the sooner I get him there, the better. But if I'm trying to get him there too quickly, then I'm not really knowing whether he's improving or not. And when do we say, oh, actually he's responding, let's wait, and when do we say ship? And I think that's going to be really hard.
That's the big pan-UK debate, really, isn't it? How you develop these services.
Do we have to say that at least NHS shift before we, I think White, I think it's Phil White, isn't it? I heard him talk, and there was some talk about some NIHSS scoring to try and say that actually there should be a certain
improvement of 3 or 4 or 5 points or whatever else.
Can I just interject as well? I mean, in terms of the trials, there was Mr. Cleaner did specify how long the patient, you had to wait with the patient before deciding a TPA failure, and in 2 others where it did, there was, I think, some other trials where they just didn't wait and they just didn't decide it.
Yeah.
And then there was 2, one where they specified 30 minutes and one where they specified 60 minutes. I mean, I suppose when the patient comes through the door, and you should be, because Mark spent quite a bit of emphasis on the time to give TPA, but obviously there's, for the ones that you're going to give intervention to, you don't want to delay that by, I think you should just get the process going and assume that they're going to go to the cath lab, and that's going to take longer than 60 minutes, isn't it? And so if, for example, if you do improve by the time they get to the cath lab, you just don't do the groin puncture, you kind of then basically say, fine, they've improved, but if you wait, you're kind of then going to have another hour on top of an hour you've waited for the TPA to work, so you could be...
But that's the issue. That's the issue of the UK.
From the person that will be shipping and sending the patient, if you ask me, I would say, the moment I feel that is a suitable candidate, especially if it's young, I'm just going to get that. I'm going to just
and you have to
start the treatment. Go. I've got one. He's fulfilled all the criteria. He's in the ambulance, and if on the way to the hospital
They get better.
improves and he
They
gets
come back.
better,
They'll come back to
you
you.
can always send them back to me. But at least,
it's a
rather than I'm
it's a
sitting there for 30, 60 minutes looking
It's a
and
pan-UK
getting to do
debate.
another
The other problem
NIHSS.
is that when they're in front of you in A&E, often they do improve, but they're fluctuating all the time. So you may get an improvement for 5 minutes, and then you kind of like
Yeah.
thinking,
That's why I'm saying I shouldn't. We see it all the time, don't we? We see it all the time. Yeah, exactly. And the other issue is the ambulance driver, because I think we've not discussed this, but from me is if an ambulance driver is bringing me a patient and I'm already quickly thinking that is going to go, do we need to be having discussions with our ambulance services to say, actually mate, can you just stay where you are? I might need you in about 15, 20 minutes to be shipping that patient across.
It's a whole UK
Because
wide.
if I go and say, you can go now, and then, oh, let's book another ambulance, again, it's all those delays in the system. You have to...
It's a real issue if you've got pan-regional systems. Or the UK goes to 10 stroke hubs or 12 stroke hubs and everything goes there.
Well, that's just not...
Which is just not possible. It's not physically possible.
It's going to have to be ship and drip, but we need to be... Those are the issues we need to be trying to kind of say, actually, from the start, if we really want to do this, NWAS need, ambulance services need to be sat on the table, and we need to have some consensus that actually for that pathway, the ambulance driver is not going to leave the patient if we really want to try and get them across. That's kind of...
Yeah, it's very different working in a central unit to working in a peripheral unit.
But most of the continent, the paramedics have been very crucial for the service.
Yeah, absolutely.
If we are going to have some conversation, we need to talk to them very early.
Well,
They have to be part of the whole process, don't they?
They do.
absolutely.
And,
They do, and but that's the whole point of the service developments. Is this has to be included, and you have to look at what the evidence shows, and the evidence shows that if you don't deliver it quickly, it doesn't matter. So actually, what you're effectively saying is that you need to deliver the IV quickly, but you also need to arrange to deliver the other thing quickly. If you're going to get your patients in, deliver the IV and plan, and think they're probably not going to open, I'll ship them. That's fine. It has to be in place to be able to repatriate immediately if they improve. That the ambulance services have to be happy moving people who've got IV TPA on board.
That was going to be another question. Is
so it's something that
who
anywhere
needs to be in the ambulance?
yeah,